Thank you, Simone. Hopefully you can hear me okay. And thank you to the Trials Methodology Research Network as well for inviting Mason and I to come today to talk about the BOTS project. So I'm just going to start off actually by just acknowledging the contribution of the BOTS co-investigator group. So the research that Mason and I are going to present today was funded by the National Institute for Health and Care Research and involved, as you can see from the slide here, collaboration with a number of different individuals across several clinical trials units within the United Kingdom. So whilst there's been some pushback with recent publications calling into question, for example, the dogmatic, well, what they call the dogmatic approach to blinding within randomized trials, generally speaking, the rationale for blinding in trials is fairly well established. So there's a wealth of evidence about the fact that a lack of allocation concealment or failure to blind certain key groups, so for example, clinicians, participants, or outcome assessors, is associated with risk of bias. But on the other hand, while there exists guidance and recommendations around the blinding of statisticians, there is comparatively little in the way of empirical evidence to guide CTUs about best practice when it comes to blinding statisticians. So as a result, we know from a survey that we conducted in 2019 that there's fairly substantial variation in practice, both within and across clinical trials units within the UK when it comes to blinding statisticians. So I guess a legitimate question to ask is, well, does it make a difference? Does it really matter? And I'm going to hopefully try to convince you with this slide that I think it is important to think about these things. So this slide here is illustrating two different examples of blinding practice one might take with statisticians. And we know from our survey that we conducted that about half of the clinical trials units had a fixed approach for all of their trials. And the examples on the slide here represent the two most common of those approaches. So in CTU-A, the trial statistician is kept fully blinded from as long as possible to treatment allocation, right up until the last minute. And they're only actually permitted access to treatment allocation data for the purposes of completing the final analysis. So right up until the database is locked, they don't get access to treatment allocation data. In clinical trials unit B, the trial statistician is permitted access to treatment allocation data, so they take a slightly more flexible approach. And this might be from the outset, or it might be at some point during the trial once some certain criteria are met. So for instance, approval of the statistical analysis plan, for example. And clearly there are benefits and potential harms to both of these approaches. So for instance, the belts and braces approach of CTU-A, that minimizes any possibility or the accusation that the trial statistician could have actually introduced bias directly through their own conduct or indirectly by their interactions with other members of the trial team. On the other hand, in CTU-B, the trial statistician there is afforded, you could argue, greater insight into the data. It might allow them to make more insightful input into the trial. And this might be particularly important in terms of allowing them to have an open dialogue with, for example, the data monitoring committee, and allow accurate and rapid decision-making if there were any issues to arise. So I suppose an obvious flaw with both of these approaches is, as fixed methods, they're fairly inflexible to the risks and needs of an individual trial. So the Blinding of Trial Statisticians projects, or BOTS projects, which Mason and I have been involved in for the past couple of years, was set up with the express aim of actually generating the evidence in order to inform and develop guidance for CTUs to follow a risk proportionate approach to blinding statisticians. So thinking about the needs of a trial rather than just following a fixed approach in all cases. So BOTS itself was split into three components, and we're going to touch upon each of these today. So stage one was a qualitative study where we looked to ascertain the thoughts and opinions of key stakeholders through focus groups. The second stage was a retrospective review of the published literature in order to see whether there was any evidence that the blinding status of the trial statistician was associated in any way with the reporting of significant findings. And then lastly, in stage three, the information or the data gathered from stages 1 and 2 was brought together in order to develop a guidance document based upon this information. So practical guidance for clinical trials units to use. So it's at this point I'm going to hand across to my colleague Mace, who's going to talk about the qualitative study. Over to you, Mace.
Thank you, Chris. So I'll talk about the first stage of our study, which is the qualitative study. So in this qualitative study, we conducted 6 focus groups with 37 participants from 19 different CTUs around the UK. 2 focus groups were statistician focused, and the other 4 were a mix of trial managers, programmers, data managers, coordinators, and statisticians. So when we analyzed the transcripts of these focus groups, 4 main themes were identified, and these themes, the first one is statistical models of work. The second one, factors affecting the decision to blind statisticians. The third one is about benefits of blinding and non-blinding trial statisticians. And the last one is about practicalities. It is worth to highlight here that these themes were identified based on the focus group transcripts, focus groups participants' opinions and suggestions, and do not necessarily reflect the opinion of the research team or the stakeholder panel. Before talking about the first theme, which is the statistical models of work, we identified 3 main roles based on analyzing focus group transcripts. These roles include, first, the trial statistician, who is typically responsible for day-to-day statistical input into the design, conduct, and reporting of the trial. The second role was about lead statistician, who leads on and has overall responsibility for statistical aspects of the trial and responsible for the oversight of the trial statistician, including advice and quality control. And the last one was the non-blinded statistician. And non-blinded statistician is a statistician who is not the trial or lead statistician that is able to access data by allocation. And the main purpose of unblinded statistician is to enable the trial and the lead statistician to remain blinded where possible. So, for the first theme, which is the statistical models, we identified 6 models of working after analyzing the focus group transcripts. The main thing about these models that all models shared that there are at least 2 statisticians involved, one typically more junior trial statistician and one more senior lead or principal statistician. In some cases, tasks were delegated to another statistician. Here in model 3, an additional non-blinded statistician was also involved in the delivery of the trial. There was an undesirable feature of some of these models, which is the incomplete oversight that the lead statistician has over the trial statistician. It's worthy to note that a benefit of model 5 and 6, where the involvement of the trial statistician and the lead statistician match, limits the possibility of partial oversight of the trial statistician. Now, in response to the question about factors that may affect the decision to blind or not blind statisticians, a range of factors was highlighted, such as types of data, study design, outcomes, analysis, and interventions. Also, external factors were identified as a factor, such as funder limitations and expectations. Personal relationships with CIs and sponsors were mentioned by focus group participants as factors that may influence the decision to blind or not blind statistician. Now, for the third theme, which is about the benefits of blinding and not blinding, some examples highlighted by the focus group participants about the benefits of blinding, including decreasing the pressure on a statistician to reveal data if they are unblinded, and reducing the perception to introduce bias, enhance capability, credibility and quality of the trial, and maintaining confidentiality. Also, there were some benefits of not blinding trial statistician, including understanding data in context, having open conversations, decreasing the risk of incorrect decision-making, and better understanding of the data, which will lead in higher quality analysis. The last theme was about practicalities and how to maintain the blind of trial statistician during trial delivery was a challenging factor raised by participants across all the focus groups. Suggestions how this could be achieved included: first, putting in place rigorous processes enabling the blinded statistician to access and request data or allocation. The second one is by giving the responsibility to data management to prepare reports and strip out data which could unblind. And the third one is by allowing the programmer to write and produce the randomization system in order to ensure that no other team members have directly seen the allocation. The participants also stated that issues of staffing and unit capacity were factors that might affect and influence the practicality to blind trial statistician. Also, the level of statisticians' experience and knowledge about blinding was also found to influence the decision whether to blind or not, as well as whether other trial staff were blinded. Several participants felt a lack of training or awareness could lead to unblinding. For example, for an unblinded member of the trial team sending information or email about allocation to a blinded statistician. Also, some participants suggested that a minimum of 4 statisticians, senior, unblinded statistician, and 2 blinded statistician would be required to enable them to allocate blinded statistician effectively. However, the availability of funding for CTUs to secure the number of statisticians for each trial was considered impractical and unrealistic, along with challenges in recruitment. And lastly, all participants indicated the need to include blinding as part of a risk assessment and use that to derive what level of trial statistician blinding was needed in a given trial based on the context. And now this is the end of my talk. Now I will pass over to my colleague, Chris.
Thank you. Thank you, Mace. So for the remainder of this presentation, I'm going to focus on the final 2 stages. So firstly, the review of practice. I'll try and go over that a little bit more briefly, because I'm sure people will be interested in hearing a bit more about stage 3 and the resulting guidance. So, as I said already, excuse me, the second stage of BOTS was a review of practice. So the goal here really was to determine, by looking back over a retrospective cohort of published studies, whether or not there was any evidence that the blinding status of the statistician was in any way associated with either the trial characteristics. So for instance, that might be, another way of putting that could be what actually influences the decision to blind or not blind the trial statistician. And secondly, to see whether there was any evidence of the blinding status of the statistician being associated with the outcome or the result of the trial. So here, what we're essentially asking, is there any evidence of a risk of bias associated with not blinding the trial statistician? So for the review of practice, we identified a cohort of around 200 NIHR funded trials. So these come from the Health Technology Assessment and Efficacy and Mechanism Evaluation funding streams. So these were published in the NIHR Journals Library between 2016 and 2020. And the idea here really was that this cohort of recently published HTA and EME funded trials should hopefully provide a cohort of very high quality studies that should be less prone to other methodological deficiencies that could potentially confound the thing that we're really interested in. So whether the blinding status of the statistician impacts the results. So we also felt that these publications in the journals library, these represent quite substantial monographs to the funder. So each of them are usually well over 100 pages long, incredibly detailed and very well reported. And so we felt it was more likely that these are going to contain many of the details that were of interest to us, but are very frequently omitted from publications within medical journals. So we developed a data extraction tool to collect a range of data from these publications, from these trials. So we wanted to know information about the trial characteristics. Of course, we wanted to know about the blinding status of the statistician, where that information was available. And we also wanted to collect information about the outcome of the trial and other potential sources of bias that might have actually influenced that outcome. So I'll just go into a little bit more detail. So we included a range of characteristics, and we'll present some a little bit later on, but this focused on things like the design of the study, the number and type of interventions that were being used, as well as the number and type of comparisons. So in particular, how many primary outcomes were there? Was there several different treatment groups for this particular trial? We were obviously interested in determining the blinding status of the statistician, and where this information was present within the monograph, we extracted that. Now, we didn't expect it to be particularly well reported overall, so we always planned from the beginning that we would contact the study authors in order to try and get that information wherever the blinding status was unclear. So specifically, we targeted the trial managers and the trial statisticians where they were named on the publication. And lastly, we extracted information, as I said, about the outcome of the study, so the primary outcome results, and then other potential risks of bias that could influence that. So this was motivated by the things that are collected as part of the ROB2, the risk of bias tool. So we collected information about the blinding status of certain groups, so participants, clinicians, and outcome assessors, the number of planned versus the number of actual participants that were recruited, as well as information about the amount of missing primary outcome data and the methods that are used in order to adjust for that or account for the missing data. I'll just very briefly mention the planned statistical analysis. So the trial characteristics were summarised descriptively without any formal comparisons. And our primary statistical analysis was looking to see whether there was any difference in the proportion of statistically significant findings between trials where the statistician was blinded versus those where the statistician was not. And we adjusted for those potentially confounding factors, and I'll say a little bit more later on when we present the results about what they were. So just a selection of the results very briefly. So we screened, as I said already, about 200 HDA and EME studies, and this was based on records within the journals library database published between 2016 and 2020. And we screened out those that were classified as being pilot or feasibility studies. And now you can see, in spite of that initial screening, there were a few that slipped through the net. So a few non-randomized trials and a few pilot and feasibility studies that were excluded as part of our screening. There were 7 studies that stopped so prematurely that we couldn't actually collect any meaningful or useful data from those, so they were excluded. And there was one example of a trial that was reported, but it was actually the long-term follow-up for the primary outcome was still ongoing, so we excluded that one as well. So after these exclusions, we were left with 179 trials that were appropriate for inclusion within our review. So for these 179 trials, we extracted the full range of data that I set out in the earlier slides, some of which we'll present in the slides that follow as well. What about the blinding status of the statistician? So as I mentioned, we didn't expect this to be widely reported within the monographs. So in the end, it was about 40% of them that reported the blinding status of the statistician, which was actually probably a bit better, more than we'd expected initially. So as I said, we went out and contacted the study authors where it was unclear. And what we found was that actually the response rate we were really pleased with. So there was, a relatively small number, 27, about 15%, that remained unclear, having contacted the authors and where we hadn't got a response from them. So yeah, we were fairly pleased with that, and a huge thank you to anybody, and some of you might be listening, to those people who responded to our nagging emails about whether they blinded their statisticians on trials they completed long ago. Perhaps unsurprisingly, the reporting of the blinding status of the statistician within the monograph was much better where the statistician was actually blinded. So people were much more likely to mention it where they had done it. I think that's not surprising. But nonetheless, it's worth just bearing that in mind when we come back to talking about the results later. So I'm just going to present a selection of the characteristics that we collected, and there are many more characteristics in this that we collected, and they're reported within the publication, and I'll give a reference at the end. It's worth noting as well that this particular table, this presents row percentages, so it's a little bit different to the sorts of table ones that we're used to. So this allows us to basically say the number and percentage that we used that were blinded for each characteristic of the trial. So for instance, within 2016, we could say that about 56% of trials published in 2016 didn't blind their statistician. And that's in comparison to about 47% of those published in 2020 who did. So there's a bit of a suggestion, perhaps a little hint there, that maybe blinding of statisticians is getting more common within recent years. This was something that was consistent with the focus group findings as well. So focus group participants felt there was a bit of a trend towards that practice recently. I'll caveat that by saying, of course, that there are about 8, well, so in 2020, there were 8 that were unknown. And of course, if those turned out to be trials that didn't blind their statistician, as we think is possibly more likely, then actually that probably starts to balance things out a little bit. So it's a bit of a suggestion that it's getting maybe more common, but I'm heavily caveating that. About 90% of the included trials were individually randomized trials, and the majority of the rest were cluster trials. So fairly standard study designs within this cohort. That's, again, perhaps not unexpected for these particular journals. And the review also suggested, so I've included at the bottom there information about whether the trials are CTIMP or not, and that's mainly because this was something of a surprising finding, at least initially. So it suggested that statisticians were less likely to be blinded for CTIMPs, so about 33% blinded, compared to non-CTIMPs, where about 42% were blinded. And this appeared to be in contradiction with what we were hearing in the focus groups. So participants were telling us they might make blinding a higher priority for CTIMPs, and again, due perhaps to the perceived regulatory pressures to do so. Although we felt one possible explanation for this might just be that there's a greater focus on interim analysis of safety data and reporting to data monitoring committees for these types of trials. So actually, it might be that whilst you start off with the intention of maintaining the blind, actually frequent interim analyses and collection of detailed safety data might have actually necessitated unblinding the trial statistician in these cases. So I'm going to skip forward now to talking about the primary results. So what was the outcome of this? Was there any evidence of any difference in the reported findings of these trials? Well, the descriptive data are included on the slide here. So you can see that around about 30% of studies reported a statistically significant finding on the primary outcome. And this looks to be fairly equally distributed, irrespective of blinding status. It doesn't seem to make a difference based on the descriptive data. However, I did mention at the beginning that we were concerned about the possible influence of confounding factors in this case. So our primary analysis model made adjustments for some of these. So in particular, we adjusted for whether or not there were multiple comparisons in play. So was there multiple treatment groups? Was there more than one primary outcome that was being considered? Whether or not the sample size was achieved. So did they reach the target sample size they set out to? And whether or not the trial was unblinded or not blinded in some other way. So for instance, participants, clinicians, or outcome assessors not blinded. I've given the definition on the slide there. So you can see from the odds ratio highlighted in blue in the first row that there's very little evidence here to suggest that the blinding status of the statistician is in any way influential on the reporting of statistically significant findings. And on the other hand, you can see towards the bottom of that table that, consistent with what's already in the literature, there does appear to be an increased chance of significant findings when one of the clinician, participant, or outcome assessor is not blinded in this particular case. So again, I'm going to caveat it by saying that the 95% confidence intervals around these odds ratios are pretty wide. So there's clearly still a bit of uncertainty around the size of any biases resulting from these features. But what I think hopefully is apparent is that actually any bias resulting from not blinding a statistician, it does appear to be quite substantially smaller than the analogous bias associated with not blinding at least one of those other key groups. So you might have noticed the primary analysis only included those studies where we could definitively determine the blinding status of the statistician either way. But we were still keen to include those studies that were unclear. So a sensitivity analysis actually included those studies by assuming that if it was unclear, the blinding status was unclear, then the assumption was that they then weren't blinded. And again, we felt that this was probably justifiable in most cases. We saw from the data I presented earlier that that was true, certainly of reporting in the monograph. So it wasn't a big stretch to say maybe people were less likely to inform us about the blinding status of the statistician if the statistician was unblinded. So that was the assumption that we employed for the sensitivity analysis, and you can see that the results were very, very consistent. We also looked at some other alternative model specifications as well. So we looked at different, including different factors within the analysis model, including splitting up those, the blinding status of clinicians, participants, and outcome assessors, and including them separately. And again, the findings of the model remained very consistent, and all of these are included in the paper as well. So to summarize the review of practice, there was a hint, nothing more than that, that perhaps blinding of trial statisticians was getting more common in recent years. It did appear that the blinding statistician was associated with certain trial characteristics. So we presented CTIMPs on the slide here, but there are some others as well. So for instance, the type of intervention seemed to be related as well to the blinding status of the statistician. Crucially, I suppose the headline result was that there was no evidence that the blinding status of the statistician was in any way associated with the reporting of significant findings. So for our review, at least, it didn't look like there was any evidence of a bias linked to not blinding the statistician. Okay, so lastly, I'm just going to finish off by talking about the third and final stage of the BOTS project. So this was the development of guidance based upon the data that we collected in stages 1 and 2. So this slide here just summarizes in a flow diagram the kind of overall approach that we took in order to achieve the guidance development. And in the slides that follow, I'm going to work through each of these steps in detail. But just to summarize, the findings of the qualitative and quantitative parts of the project were combined together in order to inform a series of provisional statements. The original plan was actually that these statements would undergo a formal Delphi process. So we were going to try and drive consensus on what should and shouldn't be in the final guidance. However, it was apparent from fairly early on within the focus groups that agreeing firm statements about what should be done with respect to blinding was probably going to be impractical and actually not particularly helpful either. So rather than trying to drive for a consensus group, we actually formed a stakeholder group, a stakeholder panel, that were able to input into the guidance in 2 different stages. So firstly, the stakeholders would provide independent rating and feedback on the guidance statements. And then secondly, they would attend, the same group of individuals would attend a workshop to discuss the statements with their peers alongside their feedbacks and their ratings. So kind of like almost like a Delphi-light process here. So an independent element and then a discussion amongst the group. And then following this discussion, this then informed the development of the final guidance document. So I'll just say a little bit about the stakeholder group. So it comprised 16 participants across 12 different institutions, and it had a broad range of different roles covered as well. So I've listed them on the slides here, but we had trial management, we had data management, we had members of oversight committee, and we had representatives from the funder, the NIHR, as well as the NIHR. So we think we got fairly broad representation within our stakeholder group, which we were pleased with. The stakeholder group, as I said already, were invited to rate their agreement with 40 provisional statements. So these came from the qualitative and the quantitative data. And the statements looked like the one included on the slide here. So they had a number of these that they had to rate their agreement with. And the main findings from this pre-workshop survey was that actually, firstly, there was unanimous support that a risk proportionate approach to blinding statisticians was a good thing, that's what we should be doing. So that was encouraging. But there was also feedback that actually agreement or disagreement with many of the proposed statements was dependent on contextual factors. So these could be both trial-specific factors as well as CTU-specific factors. And so actually, in response to this, in response to these survey findings, the stakeholder meeting focused on not just discussing and modifying the statements, but also on exploring what are those important factors that might influence the decision to blind or not blind the statistician. So the stakeholder meeting itself was then conducted shortly after the survey in November 2021. And at the stakeholder group, there was general agreement that the statements as they were too broad. They tried to cover too wide a range of scenarios, and in some ways were not sufficiently specific about what they were describing. And so there was also crucially agreement that actually helpful guidance, rather than consisting of firm statements, would be comprised rather instead of points to consider. And this was, again, as I think May said earlier, this was consistent with our focus group findings. This is what the focus group participants were telling us they wanted to see as well. So in response to this feedback, the 40 provisional statements were revised and whittled down to 21 final recommendations and considerations. And the overarching recommendation, as I've mentioned already, was this idea that the decision to blind the statistician should be based on the trial-specific benefits and risks, rather than following a kind of one-size-fits-all for a particular unit. And the other recommendations and considerations then form the basis for a guidance document with practical advice to actually help clinical trials units to achieve that risk proportionate approach to blinding statisticians. So it was based on feedback from the stakeholder group and from the focus group participants that the BOTS team also developed a BOTS risk assessment tool alongside that. So again, it's a framework, which I'll say a little bit about later, for clinical trials units in order to assess the risks, the trial-specific risks associated with blinding practice, and then to develop appropriate mitigation strategies in response to that. So the guidance document itself consisted of about 7 sections, and I'm not going to go through everything in detail. And as I said already, the link to the publication, including the guidance, I'll give at the end of the slides. But I will just include a few illustrative examples of the sorts of things that we included in there. So each of the, I should add at the start as well, that each of the considerations and recommendations comes with some explanatory text, which is intended to provide further elaboration and give examples where necessary. So I'm just going to put the recommendations and considerations on here, but in each of these cases, there's the document itself goes into a little bit more detail and provides a bit more context. So statement consideration 1.1 is under timing of unblinding, and this was one of our more prescriptive recommendations. So Here, as I've mentioned already, we were saying that if the trial statistician has got responsibility for reviewing or drafting the statistical analysis plan, then they should remain blinded up until that statistical analysis plan is approved. And again, the idea here is that it just doesn't eliminate, but it minimizes any possibility that the planned analysis might then be biased in some way by knowledge of treatment allocation. 3.3, so this is under study design. So this is fairly open, and this is more typical for the sorts of recommendations that we include. But here we make the point that for open label studies, especially those studies where other members of the trial team are unblinded, there is arguably less benefit to blinding the statistician in that case. And in fact, actually unintentional unblinding of the trial statistician becomes even more likely in that scenario. So that's just, again, something to think about, the difference between open label versus blinded studies. 4.1, so this is under types of interventions. So here we're just making the point that some interventions bring certain challenges to blinding the statistician. So for instance, an intervention might have a very distinctive safety profile that makes it stand out, or it might require the collection of intervention specific data. So both of these things actually have the potential to unblind and create additional challenges if you're trying to blind the analysing statistician. And then 7.1 under practicalities. So this is another fairly important overarching recommendation, which basically says that the resources required in order to maintain the blind of the statistician, they really need to be proportionate to the perceived benefit that you're going to get. So for example, if you've got an open label study that's going to require lots of intervention specific data being collected, then it might be in that situation that maintaining the blind of the statistician could be very resource intensive and potentially for fairly limited benefit. So it's just thinking about the trade-off in terms of resources versus benefit here. So section 2 then of the guidance deals with interactions with other groups, and one of the important topics that came up regularly within focus groups and within the stakeholder meeting related to the trial statistician's relationship with the data monitoring committee. So in 2.2, we basically make the recommendation that trialists need to think carefully about how the blinding status of the trial statistician impacts then on interactions between the statistician and the data monitoring committee. So the guidance also includes kind of suggestive models for dealing with this interaction. So according to the blinding status, what models of interaction with the DMC might you use, along with an exposition of the possible risks and mitigation strategies you could follow. So I'm just going to focus on two of those, which relate to those two common models that I talked about at the very start, but there are a number of others that are included within the guidance as well. So first of all, whether trial statistician remains blinded, as was the case for our CTUA at the very beginning, this potentially limits and hinders an open dialogue with the data monitoring committee, at least with respect to potentially unblinding data. And to mitigate against this, what we are encouraging is that there's a dialogue within the open session, but at the same time, you have to be careful not to unblind within those discussions, but just making sure that any queries that relate to unblinded data are discussed in the appropriate fashion within the open session of the DMC. Also, one can involve a non-blinded independent statistician. Mace was talking about this earlier. So involve another statistician in order to deal with those aspects of the data that the trial statistician is blinded from. But it's really important that they then have the knowledge and the experience to adequately answer the potentially unblinding queries of the data monitoring committee. So on the other hand, what about for CTUB, where the trial statistician is unblinded? Well, as we said at the time, this promotes a more open dialogue with the DMC, and it comes at the possible risk that then the trial statistician might either directly or indirectly impart some bias with their knowledge of treatment allocation. Knowledge of treatment allocation alongside the knowledge of emerging trial findings as well. And so in this case, mitigation strategies we already talked about, making sure the analysis plan is approved prior to the unblinding happening. But then you also have the option of actually limiting the trial statistician's involvement in any study decision-making processes that follow unblinding, or at least documenting it very carefully, what was decided and why. Okay, so I'm just going to finish off now with some screenshots from the guidance document. And one of the other things that we do within the guidance document is actually explore the benefits and risks and mitigation strategies more generally. So on this slide, I've just included some of the benefits of blinding versus not blinding. And we've touched upon a number of these already throughout the presentation, so I'm not going to repeat those. But essentially what's happening when one way you can think about it is when choosing between blinding or not blinding, we're making a bit of a trade-off between the statistician being able to have an open dialogue with either blinded members of the trial management group versus unblinded independent members of the data monitoring committee. So it's thinking about some of those, trading off those benefits against one another. On this slide, it's just presenting some of the potential harms and risks of each approach. And again, we've covered some of these, but one that we haven't talked about up until this point, although I think Mace possibly mentioned it, is the hopefully rare, but nonetheless real possibility that actually an unblinded trial statistician with knowledge of treatment allocation and knowledge of the emerging findings of the trial might be subject to undue pressure from someone within the team or somebody outside of the team. And so as part of the guidance, one of the things we suggest is that actually statistics teams or stats teams within a trials unit need to think about this quite carefully and think about it as an important part of their induction and training to ensure that there's appropriate support in place to deal with those sorts of issues should they arise. We also expand on the possible mitigation strategies, and again, we've touched upon some of these already. So whether we're blinding or not blinding the statistician, one of the things that's obviously important is that this is clearly communicated to other members of the trial team and all the oversight committees in order to prevent against any accidental unblinding or issues arising of that nature. And lastly, some practical considerations to think about for each approach. So again, whichever approach one decides to take for a given trial, there will be implications for resourcing. There'll be implications for other groups within the trial management team. So as an example, so maintaining the blind of the statistician might require more complicated database builds. It might require identification and concealment of potentially blinding fields. On the other hand, deciding to unblind a statistician might require a shift in resources in order to prepare and approve an analysis plan at an earlier stage. So I'm just going to finish off now with just a couple of screenshots from the risk assessment tool. So while the guidance document is trying to describe the risks in a very general way, in a general sense, what we hope is that the BOTS risk assessment tool provides clinical trialists with a framework to identify the trial-specific risks and identify relevant mitigation strategies to deal with those. So again, this is broken down into 6 domains, and each domain includes some rows with suggested possible risks. But the crucial thing is they're not intended to be an exhaustive list. So there are blank rows in there for people to think about adding their own risks that might be specific to their trial. And for each risk, the trialists are invited to think about what the likelihood of them arising are, what the implications for the trial integrity. So this is quite similar format that you would have seen for a more standard trial risk assessment. And then also to think about possible mitigation strategies to deal with that. At the very end of the risk assessment tool, you're then invited to think about what's the overall risk associated with each approach, taking into consideration the potential for mitigating against those risks. And then there's space for trialists to document and justify their decided approach. So we hope that this is something that will be helpful for kind of going back retrospectively, justifying why you took a certain approach for a trial and what were the things that you did in order to try and guard against the risks you identified. We also hope that the risk assessment tool can be completed at different stages, so either prior to securing funding, which might be relevant to deciding upon resourcing, setting the funding value at the right level, or you might do it during the design and setup phase in order to help with allocation of statisticians and trial staff to projects. It could even be applied halfway through the trial, so it might be that there's an unexpected circumstances arise where you have to potentially rethink your strategy. You might decide that actually you do need to unblind, and then you have to think about what the possible challenges that you might face in that situation. So just very briefly on the strengths and limitations of the project. So bots, we think benefited hugely from having such a diverse and expert panel of stakeholders. This, as well as the breadth of our focus groups and the literature review, means that we feel confident that the findings are likely generalizable to clinical trials units, at least within the United Kingdom. And again, as long as there's a reasonable uncertainty and almost equipoise around the blinding approach, and that might not necessarily always be the case for all settings. One of the challenges that we faced, both the qualitative project and the review of practice, was this issue around wide heterogeneity in how to define blinding of a statistician. So, for instance, we took a fairly hard line within the bots team. So we felt that coding of groups, for instance, labeling groups A and B, doesn't really constitute robust blinding, is quite easily subverted in many situations. And while we had some control over that within the focus groups, within the review of practice, we were largely at the mercy of the study authors in terms of what they deemed suitable and robust blinding. So we expect that this probably created fairly heterogeneous groups for the review of practice, and might potentially have contributed to making it more challenging to detect a difference between the two groups. But as such, we think while we included a reasonable number of trials within the review, it almost certainly would have benefited from being a wider review with a larger number of studies in order to increase the precision of our findings. So just to summarize, the key finding was that from bots was that actually the decision to blind the statistician should be ideally based on the trial specific benefits and risks in most cases. And we developed the bots guidance as well as a risk assessment tool. And our hope is this will actually expand the understanding of how and when to blind the trial statistician. We hope it also lays the foundations to apply evidence-based decisions regarding practice, and we hope it will also serve to help trial teams in the decision-making process. I'm just going to end by saying a huge thank you to everybody that contributed. So special mentions to the co-investigator group and also the stakeholder group who are listed on this slide. But a huge thank you to everybody that took part in a focus group or responded to our requests for further information. Again, I would like to thank the funder, so the NIHR, but also the UK CRC and the Trials Methodology Research Partnership for their support in advertising and delivering the research. And thank you everybody else for listening as well. So I'm just going to finish by throwing up the references here. So study documents are all available on the bots webpage, which is on the CTU website. And there's also 2 publications in trials which detail everything that Mason and I talked about today. But thank you, everyone.